So, welcome to a video recording with a conversation that Stanford undergraduate student Tim Jim and I are having with Dr. Mudji, who is an expert in explaining to us today the complex situation in the Democratic Republic of Congo, which is a post-conflict country. And the purpose of our conversation today is to understand the complexity of being a doctor in the DRC. Dr. Mudji has an enormous amount of experience working in the Congo, and currently he's training at Oxford University in health service improvement in low resource settings. So we're thrilled to be with him today. I'm Dr. Ruth Gibson. I'm a scholar at Stanford University. And the purpose of this conversation is to help the public understand more about what's going on in the DRC, what's happening with health, and some of the complexities of being a doctor. And with that, I'll hand it over to you, Tim.
Yeah. Thank you, Dr. Gibson. I'm Tim. I'm a Stanford undergraduate, a senior this year, and I'm currently supporting Dr. Gibson in this project. Dr. Mudji, thank you for being here as well. I think we're just going to go ahead and jump right into the first question, which is, please tell us a little bit about yourself and the work you do.
Yeah, thank you very much. My name is Mudji Ekchak. I'm a physician and I have chosen to work in a remote poor region of DRC in the with Bandundu province. So I have been a physician since I think now almost 16 years. After my medical school, I decided to come back in my village where I grew up to serve the poor population. And then I found the opportunity to be trained on family medicine. I did that training for 4 years. And then after 6 years, I became myself in charge of education. And over the years, I have understood that research holds an important places in our system to try to understand our problem, our challenges. It requires some research skills. Then I started to learn research by myself, like autodidact. And then I've created a small unit of research in Vanga Hospital. And I have also got another master degree on global healthcare leadership in Oxford. And now I'm doing a PhD on health service improvement in low resource setting in Oxford.
So, as you work with the international community, what's the number one issue that you want international policymakers to understand, or global health leaders to understand about the health of local populations in the DRC?
Yeah, that has been the most important challenge is to help people from the North University or Western University or this big organization, because now what we observe, like in Vanga Hospital, is that this World Bank and other big organizations come in our town with their own projects. They know everything they want to do, and they don't talk to the people in the community. They don't understand the local culture, and they come with big projects to implement, and most of the time it fails. I can give you an example to explain. For example, they can come in our hospital, Vanga Hospital, and say, okay, in your hospital, we have a lot of preterm death, and we think that you need CPAP machine to help your premature and low birth weight improve. This is what they do. They just come with machine and they give to the hospital, but they don't understand the culture, how this machine will be used, the number of nurses in the ward. They don't know who will be in charge on technical problem. They just come and give the machine and go back. And we can find this in many situations in our country. So to summarize, I think what I would like the leaders to know is to understand first the system. After understanding the system, then they can come with an implementation of intervention, because the knowledge of the local system is really important. If not, we will continue to lose money. because what I would say to these big leaders is that they should stop wasting money. In my opinion, the majority of the program is just waste of money.
Can I ask a follow-up question, Tim, before we go on? Dr. Mudji, so I hear you, and I think that that's imperative. It also, I think, if you were to have a team of people in front of you today, now, and to explain to them some of the fundamental pieces that they need to understand about the local culture and the local systems, how would you explain that to them before they spend time with you on the ground?
So I will say to them that it's important to talk to people, the local leaders, and also they can take time themselves to observe. If they talk to the local leaders with a specific question to understand how people work, how people think, and how then we can change the behavior. I know it's really hard to change behavior, really hard to change the behavior, but it will be more hard is if you don't understand the local culture, the local behavior, how people think. If you want to build a maternity in a community where it is not allowed to have a man who is a nurse, so the woman will continue to go and deliver in the forest. So that question are really so important for people to know. And it start by talking to people, making a round with the local leader, try to understand.
That's incredibly helpful. Thank you. Tim?
Yes. So our next question, you shared that you're sometimes involved in education at Vanga Hospital, and you're often involved in training the next generation of Congolese doctors. How do you train your future doctors for the wide range of health challenges in the DRC and with the limited healthcare infrastructure?
Thank you very much. This is another challenge. I would like to start by explaining you our system, education system, specifically for physicians, how they are trained. In DRC, you go to university for 8 years of medicine. So to become a physician in DRC, you spend 8 years. And after that, you finish your medical student, you don't have an opportunity for specialization. So I can say that up to 90% of physicians after the completion of medical study don't know where to go, what they will do. And I understand myself, I face this situation. And what we think, what we thought was good for us here in Vanga Hospital, we have created a local system of training. So we train our physicians to give them skills so they can do more to help people in poor region. Why this? Because in this big province of Bandundu, the great province of Bandundu, we will never see a specialist in internal medicine, obstetric, and surgery to accept to come and live in this poor region. And the solution for us was to organize a training that will help people to have in the local village or a place like Vanga, someone who can do C-section to help women, someone who can do newborn resuscitation if possible, someone can do at least 70% or 80% of health problems in the local community. And this is the way we are working. The problem is that we have still 20% of problem we cannot resolve because our referral system doesn't work in the country. So it's difficult. Here in Vanga, we receive some percent from Kinshasa. And when you talk to the person that we cannot do something for you, you should go back to Kinshasa, it's a big challenge for this person because they know that it's quite difficult. So generally, we cover up to 75 or 80% of health problems we receive in the hospital. But for the 20%, we don't have skills, we don't have infrastructure, and we are obliged to refer them to Kinshasa. Unfortunately, 99% of them go back to their village. They can go to Kinshasa because it's another complex problem.
So, Dr. Mudji, can you talk to us a little bit more about some of the additional complexities of working in Vanga in comparison to Kinshasa, as you were describing, and elaborate a little bit more on the story that you brought up earlier about, women who are going back to the forest to give birth because there are not their cultural norms are not being respected in the hospital setting from time to time. Can you tell us some more of those stories?
Yes, I think we have the main problem talking about infrastructure is we don't have much infrastructure. We have really limited resource in our lab. We cannot do scan, and we have to use our mind with a long list of differential diagnosis to say we think probably at 90% or 70% or 5% of the time, this is the most probable diagnosis. And do we have the treatment? Then we treat it. The example is with tuberculosis, for example. Sometimes it's easy for us to make an evidence of pulmonary TB, but if it is not pulmonary TB, then it's become really a challenge for us for diagnosis. And we have a long list, we make a long list of diagnoses and we start eliminating diagnosis until we get one, two, or three. And then the next question is, among these three diagnoses, what is the one can be treated locally here in Vanga? For example, if it's TB, then we can say, okay, TB can be treated. We don't know exactly, but we give this person a chance of 50 or 30%. So we treat like TB. These are the main challenges we have. And we face these kind of challenges every day, even for infrastructure. Sometimes you know that this is the diagnosis, it is a cancer, this cancer can be treated, but you don't have the treatment. What you do is you send the person to Kinshasa, but you are not sure that this patient will go to Kinshasa to find the treatment. But everywhere in the country, the system is really complex. So it's not easy to have money because people pay out pocket for their healthcare. There is no really social system that can support someone, for example, with chronic diseases and other kind of problem. So these are the challenge we are facing in the village. Probably the same challenge exists in Kinshasa. But with regard to the culture, so it's really important to take into account the culture of the population. I have taken the example of a woman delivery. I went to a remote village with a nice maternity was built by I don't know which founded the building of that maternity. But when I looked out and in the recorder, there was no delivery, no enough delivery. And I asked the question why. They said to me that in this health center there is only one man and that man must do everything, even delivery. But in our culture, no man will accept his wife to be helped in delivery by a man. So this is something with the culture. The person who funded the building of the maternity should think about that we need nurses, women, we need to train them, we need to build in a place a good system of antenatal care and so on. And most of the time we missed because we think we rely on quick solution. Now we don't take time to build a system that will sustain for a long time. We are quick to get the results, and by the end we fail, or the implementation we try to work on doesn't sustain for a long time, just for a short time, and then the system is again broken.
Thank you. So I'm currently a university student, like I shared. And I'm curious, what would you say to a university student, maybe say in a country like the United States, who wants to make some change in global health, but doesn't really know how? What would be the most impactful thing that they could do?
I think the more thing would be to understand first the problem in systematic thinking. I think if we use systematic thinking or the broad view of the problem, and then we can learn where we can start and fix what can be the first problem to fix. It can be first education, for example, of the population. It can be something simple that can be fixed and resolve all the challenge in the system. But we, as I've said, now the problem is we want the results today. We want implementation today, and we want the results today. I think in the complex country like DRC, it will never work because it's so complex that we need really to learn in details to map, if I can say that. We can map our problems, and we can use all kind of frameworks that exist to learn the problem deeply and come up with the solution. I can give an example of, I've already given an example of CPAP with newborn people come and say, okay, we give you CPAP. They think that it will reduce newborn mortality. It will never. No. I can also explain what we observe since I was around 5, 6 myself. I suffered a lot with a lot of malaria. Some of my friends passed away due to malaria, but until now we are facing the same problem of malaria. Why? Because the main intervention is to give medicine, or the same problem with tuberculosis. We know that tuberculosis is related to nutrition, but for decades we are just providing medicine. There is no enough intervention to help people to become independent, to build their own wealth, agriculture, farming, so they can have food, and then can have in a good health, nutrition, and then they can avoid the TB. So these are complex problems and with hard solutions. So I don't say that what people are doing are not solutions. They are solutions, but I would prefer that we go deep in found tackle the root cause of the problem, and that solution will then sustain for years.
So to build upon that theme, Dr. Mudji, about digging deep into the underlying problems that are facing the DRC, can you paint for us and paint for the viewers here today your vision for the future of the DRC, because you've committed your life and your career so far to improving health? Can you tell us about what you envision and what you're working towards over the coming decades?
Thank you. I think I'm focused on improving maternal uh, and newborn and child health in this in my country, because I think that women, newborn, and child are people are vulnerable to all kind of the problems. I think in the coming 10 or 20 years, I will continue to work first, build my research unit I have created. So I started by myself to collect data, write papers, try to publish. I've published some papers with support of some friends. And now I've created this unit in Vanga Hospital with 2 or 3 nurses and 2 other physicians who are help me as volunteers. So we don't have a fund. My idea is to apply for funds and support my project. So in our organization, we have 13 clinics across the western part of DRC in the Bandundu and Congo Central province. My idea is to implement improvement here in Vanga Hospital. After I found that this implementation work, then I will start implementing in other hospital, and then across the country. Now, one of the problem we had in the hospital in the past was just surgical site infection after C-section. So women were spending weeks in the hospital because there was a big problem with the infection control in the hospital. And I've used the same technique. I've gone to talk to the people to understand what is the root problem, because in our culture we have the culture of blaming people. No one want to accept the responsibility, accountability. It's always that other person who is in charge, the responsibility of our suffering. So what I tell to people is, I think we should work together. We should stop blaming each other, and we have succeeded with small improvement in our hospital. And now I'm thinking where I can find additional funds to implementing in other hospitals. They are asking me to help them, but I don't have money. What I can tell you is that actually I'm using a part of my revenue to help the hospital, because this is my passion. I don't support saving people's suffering. So I divide the small amount of money I received for myself and my family to share with the community, and if possible to do some improvement in the hospital. So in the coming decades, I would help to continue to work to help my research unit become a big one and support our health system in DRC.
So, Dr. Mudji, I'd like to, on behalf of the global health community, thank you for your time here today. The insights that you share with both Tim and I, but also the people watching this online, are incredibly valuable in terms of how we work together as a community, and some of the challenges that you're facing in the DRC, and the importance of the ways in which the global health community engage with our partners in the Congo as we move forward into the coming decades. And with that, I'd like to thank you both.
Yeah, thank you very much. There was a question, if I remember, it was about a story. There is a story, maybe you can find it on internet. It's about the twins, conjoined twins. I was called to help the conjoined twins. It was a very tough situation for me. I received them from a very remote village, a poor family without money, and they were desperate, and they could never imagine where to find support. I received them, tried to contact people, and tried to organize surgery in Kinshasa. It was really a successful story. Unfortunately, one died. Why? Because of malaria. We have everything to treat malaria, but if we don't have a good system the system that works, even malaria will be a problem. And after that, here in Vanga with some friends, we found we work on fundraising, and we make some money. We made some money to purchase medicine for Vanga Hospital, because sometimes medicine is a problem. Yeah, last week I went to see the data how we have improved the treatment. I found that from the year 2023 to 2024, 5, we have increased the number of people who have access to malaria treatment to 50%. That's really incredible, and for me, it's a big achievement that now more people are having access to treatment. It started with the story of twins, conjoined twins. One passed away due to malaria, and I didn't say, okay, nothing to do. I tried to find solution, and I think now I have result. Maybe I will share with you the short thing I have written on the report.
And I think that we can link that in the video down below. So for those of you interested in learning more about that story, you can find more information about that in the link below. And with
Thank you
that,
very much.
Tim, I'd like to thank you, and Dr. Mudji. This has been incredibly insightful, and I think of enormous use for the global health community. So thank you.
Thank you very much.